Hi, this is John Pagel, and again, I'm going to discuss some of the newer agents that were presented at the American Society of Hematology meeting in San Diego in December of 2016. These are newer agents in development and for therapy for patients with chronic lymphocytic leukemia, or CLL. A couple of new drugs are in advanced development that certainly are worthy of notice. One of them is a drug that gained a lot of attention at the ASH meeting in 2015 and now has been updated in a couple of studies in 2016, and that's a drug called acalabrutinib. Acalabrutinib is what we like to say, second-generation inhibitor of an enzyme known as Bruton's tyrosine kinase, or BTK. It turns out, of course, that BTK is a target of the first-generation BTK inhibitor, known as ibrutinib. Again, acalabrutinib was presented at the ASH meeting in 2015, showing excellent activity with very few adverse events and to be very well tolerated. And now it was updated in a couple of studies. One study of particular note was for patients who were intolerant to ibrutinib, and that many of those patients could go on to acalabrutinib and actually have a response that was maintained, and that their side effects that they had that may have been important for them coming off of treatment with ibrutinib were not found when they switched over to the acalabrutinib. This was a study led by Farouk Awan from Ohio State University, and I think this is very important to know that if side effects drive people away from a drug that's working, there's another drug that may be in the pipeline, on the horizon for people that works in exactly the same way, but may not have those side effects. Acalabrutinib was also looked at and presented in a study by Peter Hillman, looking at the worst types of patients with CLL in that they may have a transformation of their disease to a more aggressive form. That's something we call a Richter transformation. That was presented at the meeting, and the results were quite impressive in very, very difficult patients, patients who had very advanced disease and again had their disease transformed to, again, a more aggressive form. Acalabrutinib is in, again, advanced development. I would say that we need, of course, more time to follow up on these patients and the use of acalabrutinib. But in particular in these settings for patients with disease that is not responding, or I should say intolerant to ibrutinib, or perhaps become more aggressive, that people can actually have significant benefit. I'll also touch on a very important drug known as TG-1202 that was presented extensively at the meeting. TG-1202 is a very exciting drug in that it is another second-generation drug from one that we already have approved for patients with CLL. TG-1202 is a PI3 kinase inhibitor, and the second generation being that it's a perhaps new and improved version of the previously approved first-generation drug known as idelalisib. TG-1202 suggests that it may not have the same aggressive toxicity profile that sometimes, albeit rarely, we do see with idelalisib, and in particular perhaps we will see less diarrhea, less pneumonitis or pneumonias or lung inflammation, and perhaps less inflammation in the liver. This drug has continued in development, and we're very excited to see where that leads us in the next game-changing type of drug. Of course, I should point out that these agents are not all by themselves. We like to combine them in many ways, and combinations are certainly the way to go in the future. And in particular, I'll mention a very important study that was led by Jeff Jones from Ohio State University, also presented at ASH, that used a combination of drugs known as obinutuzumab, ibrutinib, and venetoclax. I've already mentioned the ibrutinib, which is a BTK inhibitor. Obinutuzumab is a newer generation anti-CD20 antibody that has excellent activity. And venetoclax is a new drug that targets a protein known as BCL2, and this actually induces cell death in the CLL cell. So the combination, again, of obinutuzumab, ibrutinib, and venetoclax was used in a small trial, relatively few patients, but still shows that this combination can be very well tolerated, and that the side effects are very manageable, and that the efficacy or the activity is quite impressive. Everybody who was treated showed a response, and in fact, many of these patients got complete remissions at a very short follow-up. And furthermore, many of these patients had elimination of what we call minimal residual disease, either in their blood or their bone marrow, or both. And minimal residual disease clearance is very important for extending what we call progression-free survival. This is looking down at a very deep level to see if we've eliminated any of the CLL cells. It's a method to actually make sure that in the blood or the marrow we have done an excellent job of controlling the disease. Other combinations are certainly in development, and just for completeness sake, I will mention that there are trials in development using all kinds of combinations, and the TG1202 trial is certainly in development and in combinations as well, and we'll see more about that as we move forward. A very exciting time for these new drugs in CLL, not only as single agents, but as combinations.